Uh, Thank you. Hi, this is Marianne Fisanick, and I'd like to thank everyone, especially MedEvent, Marcy, the Indiana ACDIS chapter, and for everyone that's attending today to watch this presentation. And I do apologize. Please accept my apologies. I live in Western Pennsylvania, and we're having some pretty nasty, wicked weather with some high winds, so I was the technical difficulty, so my apologies. We can move on to the next slide. So I just want to talk to you a bit about pediatrics today. And first of all, the three types of malnutrition in the pediatric population. So the first one being like a primary protein energy malnutrition results from a diet that lacks insufficient sources of protein. It's more common in the United States, usually a complication of AIDS, cancer, chronic liver failure, inflammatory bowel disease, or other malabsorption type diseases. It can develop gradually in children with chronic diseases or more acutely in patients that have acute illnesses. The second type of malnutrition would be kwashiorkors, also called a wet protein malnutrition. It's a form of protein malnutrition characterized by protein deficiency. This condition usually appears at about the age of 12 months when breastfeeding is discontinued, but it can develop anytime during the child's formative years. It causes fluid retention, edema, some dry skin, peeling skin, and hair discoloration. The third type of malnutrition is marasmus, protein energy malnutrition disorder caused by total calorie energy depletion rather than the primary protein depletion. Marasmus is characterized by a stunted growth and muscle tissue wasting. Marasmus usually develops between the ages of 6 months to 1 year. Once the child's being weaned from breast milk, and who also suffer from conditions such as chronic diarrhea. The one thing I do just want to caution you, though, on is we just want to make sure and always clarify with the physician if that pediatric patient does truly have kwashiorkors or marasmus, as these would be target diagnoses for auditors and for the OIG and things. So it's best to clarify if the physician is writing those types of things. And with malnutrition also, you know, you want to make sure that you have your evaluation management, treatment, dietary consulting, supplements that are given, etc., TPN. Okay, then we're going to go, we're on to this slide now. So the differences between marasmus and kwashiorkors, as we can see here, with marasmus, it can occur before 6 months. The hair is dull and dry. The skin is thin, wrinkled, and loses elasticity. More extensive impairment of biological functions. The patient looks emaciated. They're treated with vitamin B and a nutritious diet. On the other hand, kwashiorkors usually does not occur before 6 months. The hair is discolor. Skin lesions are present, edema. They may not lose weight, they look bloated, and they're treated by adding protein, so they do need that protein treatment. The next slide. So the severity of malnutrition, we have mild, moderate, and severe. So with mild, the weight loss in the child or adult, or lack of weight gain in children leading to an observed weight that is between 1 and 2 standard deviations between the mean reference value for that population. So you might say less than 5% weight loss. You have some fat loss, muscle wasting, and fluid accumulation. A bit of information about moderate malnutrition. So the weight loss in the child or the adult, or lack of weight gain in children leading to observed weight that is between 2 and 3 standard deviations between the mean value of that reference population. So you might say between 5 to 10% weight loss, inadequate intake, fat loss, muscle wasting, and some fluid accumulation. And severe, so your severe weight loss in the child or adult, lack of weight gain in a child leading to an observed weight that is at least 3 standard deviations below the mean for that population. Possible reference would be greater than 10% or greater than 10% weight loss, scant intake, so they're taking in less and less foods. You're having fat loss, muscle wasting, and fluid accumulation. So on to clinical indicators, slide number 5. If we could just go up one slide. Thank you. So we would have unexpected or unexplained weight loss of greater than or equal to 5%, decreased appetite. So maybe these children have food intolerance, or they're poor feeders. They have an aversion, or oral aversion. They can't retain calories. They have disease stress factors. Maybe they're eating food, and after they eat food, they immediately have diarrhea. So you just have to think of all those things and put the whole clinical picture together. They could have a history of Crohn's, short gut malabsorption, or gastric surgery. So all things to think about when you're reviewing that chart. Presence of a gastrostomy tube, indicating that they would need nutritional supplements. BMI be less than 15th percentile. Current weight percent to ideal body weight is less than 90% ideal body weight. Documentation or descriptive factors. So a lot of times, your physicians might write something like thin appearing, or wasting, or loss of fat and or muscle. The other thing, they may say things like frail. So just look for those descriptive terms that they're using. So tips for providers. We want to make sure that the physician would document the severity, the type, and the cause of the malnutrition diagnosis. We also want to consider documenting malnutrition when the following are noted: that when they're receiving any type of nutritional support. So are they receiving supplements like an Ensure or Boost? Are they receiving TPN? Are they receiving feedings through an NG tube, a J tube, a gastrostomy tube? Do they have a psychiatric consult? Are they on appetite stimulants? So when you look down through their list of medications, you're thinking, why would this person be on Megace? Dietary consults. They're saying and ordering Monitor INO, daily weights, strict calorie counts, things of that nature. So we want to just always look for those types of things. Anything that can be a clue. So if you find one item in your chart, then you just keep looking and reviewing and digging. So, okay, our next slide is a graph, and slide number 7. And on the top there, you can see this is a classification with 6 of the indicators, and it would be normal, mild, moderate, severe kwashiorkor, severe marasmus, and protein calorie. And I'll let you read this on your own, but first of all, you've got your weight to length on the WHO chart, 0 to 2 years, and then your BMI from the CDC, 22 to 20 years old, corresponding Z-scores down the left-hand column. Current weight percentage of ideal body weight, failure to thrive or decreased growth velocity, height or weight, percentage weight loss based on usual weight. So that's a good indicator to look at. So what was their normal weight maybe 6 months ago? What is it now? And then figure out the percentage of the weight loss. And a lot of times your dietitians will do that. Estimated intake, are they meeting, or is it less than their estimated energy needs? If less than 2 weeks of age, consider weight greater than 10% below birth weight, and if severe malnutrition, physical criteria to follow to classify. So those are the classifications, and based on those 6 categories there, you can see where you'd fall, either, again, normal, mild, moderate, severe, kwashiorkor, marasmus, or the protein calories. So, okay, that's pretty much that slide, and then we can start to move on to our case study for malnutrition. So here we have a chief complaint of weight loss. This would be a 15-year-old male that has a history of intractable epilepsy, was referred from the neurologic clinic. Patient had significant weight loss in the past 6 months following a vagus nerve stimulator for epilepsy. On March 1st of this year, his weight was 63 kilograms, and that put him at the 75th percentile for his height and weight. And then today, his weight is 39.9 kilograms, which is less than the 3rd percentile. Mother reports that the patient refuses to eat and clenches his teeth, will not swallow. He's drinking a little better than he's eating. Before March, he was eating very well, but over the past few weeks, he is only eating maybe about a half a bowl of chicken noodle soup a day. The etiology of the decreased appetite is unclear, but is thought to be due to the vagus nerve stimulator. and possible like an oral aversion to some foods now. So if we go to the next slide, when we figure all this out and we put in that there could be a complication of disorders of the nervous system, so complication due to a nervous system device, in the APR world, that's going to take us to APR-DRG 058, and he has some other secondary diagnoses, which would include hypernatremia, intractable convulsions, and epilepsy and loss of weight. So right now, we're standing at an APR-DRG 058 with a severity of illness of 2. So what we're going to do here is, with that great amount of weight loss and all the other descriptors, we'd like to tee up a query for severe protein calorie malnutrition. So if we do query for severe protein calorie malnutrition, or the degree of malnutrition, and the attending physician would include that in his documentation. He rolls the severe protein calorie malnutrition in. That moves us from DRG 58 with an SOI of 2 to a DRG of 58 with an SOI of 3. So not only does that increase your relative weight, and it increases reimbursement, increases your quality scores, and it also is much more descriptive of the record and reflects a better picture of what is occurring with that patient. There is not a listing here for risk of mortality, but I just wanted to speak to you about that. So along with the severe protein calorie malnutrition, the risk of mortality would also increase with the diagnosis of severe protein calorie malnutrition. And we just want to make sure that we don't gloss over risk of mortality, because risk of mortality is very important from a morbidity and mortality perspective, and also from a quality perspective. So we want to make sure that we're capturing all of the diagnosis in the most specific manner and the most specific and descriptive manner that we can. So, and of course, you want to tee up your query with your clinical indicators, your risk factors, your monitoring, evaluation, and treatment for the severe protein calorie malnutrition. So, okay, I think we can go on to the next slide, which is the morbid or severe obesity BMI for age, weight, status categories, and corresponding percentiles. So for underweight, it would be less than the 5th percentile. Normal or healthy weight would be 5th to the 85th percentile. Overweight is 85th to 95th percentile. Obese is 95th or greater, and severe is 99th percentile or greater. Morbid obesity tips. So we want to show you some tips here for documenting obesity appropriately. So we want to make sure that we include descriptions such as overweight, obesity, morbid obesity due to excess calories, or drug-induced obesity. If it's drug-induced obesity, we want to make sure that we include the associated drug. We want to document the body mass index. The criteria that the CDS or the coder might be looking for when reviewing or abstracting would be, again, the description of the type of obesity, specificity of the drug, any nutrition notes, BMI, and weight to age percentile. And they would code all of those, and the CDSs would be looking for those whenever they're doing their review. Our cutoff points, which would be slide number 13. So these are cutoff points for the 99th percentile BMI according to age and gender. So this takes us from age 5 to 17, boys versus girls. At age 5, the 99th percentile BMI for a boy would be 20.1, for a girl would be 21.5. At age 17, for boys, the BMI for about the highest 99th percentile BMI would be 34.4, and BMI for a girl would be 40.8. So very high, as you can see. On to the next, the obesity case study. So the initial documentation shows a 16-year-old patient with a traumatic fracture of the left femur following an all-terrain vehicle rollover accident. And in the record, the patient is described as heavy. Okay, we'll just go down one more slide. So this child had a hip and femur fracture repair, and that takes us to APR-DRG 308 with the SOI of 1, which is mild. And after further review of the chart and the description of heavy, we need to get some more information from the physician, the dietitian, etc. And so we would tee up a query for the morbid obesity, and if the physician did roll in the diagnosis of morbid obesity, that would take us over to a APR-DRG of 308 with severity of 2. So again, your severity of illness increases, your quality increases, your relative weight increases, your reimbursement increases. So, okay, so that's our obesity case study because his weight for age ended up being at the 99th percentile. Our next grouping we're going to start on here would be with anemia. So anemia is a condition having fewer than normal amount of red blood cells or lower than normal hemoglobin. Normal varies by age and condition, so you always want to check on that. Of course, their age and what your particular lab says the normal value is for hemoglobin or hematocrit. Anemia results when not enough red blood cells are produced or when the red blood cells are being destroyed or lost too quickly. Then we have neutropenia. It's an abnormally low count of neutrophils, white blood cells that help the immune system fight infection. Thrombocytopenia is an abnormally low platelet count. Platelets help the blood to clot. Thrombocytopenia sometimes is associated with abnormal bleeding. Pancytopenia is a reduction in the number of red blood cells, white blood cells, as well as platelets. And then aplastic anemia is a syndrome of bone marrow failure. So patients with aplastic anemia do indeed have anemia and lack of formation of red blood cells, which is why they're referred to as aplastic. One other thing I just want you to consider and just think about would be a diagnosis to review for maybe a chemo-induced or drug-induced pancytopenia, which in most cases would increase your severity of illness and risk of mortality. So if a child is receiving either medication or chemotherapy that would wipe out their white blood cells, red blood cells, and platelets, etc., many times they would suffer either a drug-induced or chemo-induced pancytopenia. And, you would want to maybe look for this, especially with chemotherapy. The nadir, or the low point, would occur about 7 days after the chemo was administered. So just something to keep in the back of your mind, just to think about. Our chronic blood loss anemia is caused by long-standing moderate blood loss. So it's just almost like a slow, continuous loss of the blood. Anemia of chronic disease can be thought of as an acquired decrease or diminution in red blood cell production. Iron deficiency anemia is very similar to most anemias of chronic disease, but can be distinguished by lab studies, as we can see in the next slide. So different types of chronic blood loss anemia. Here we're comparing anemia of chronic disease to an iron deficiency anemia. And you can see in anemia of chronic disease, for example, maybe a chronic kidney disease, your iron level is low to normal, transferrin is low to normal, transferrin saturation low to normal, ferritin is normal to high. Your transferrin receptor levels are normal, and your transferrin receptors to log ferritin are low, less than 1. Versus your iron deficiency anemia, where your iron, transferrin, and ferritin levels are all low. Iron, transferrin saturation, and ferritin levels are all low. Your transferrin level is high, as well as your transferrin receptors. And transferrin receptor log to ferritin is high, greater than 4. The transferrin receptor log aids in the diagnosis of iron deficiency anemia versus the anemia of chronic disease. Our next slide here is acute blood loss anemia, which is evident via hemoglobins within 3 to 4 hours after blood loss. So repeat testing usually occurs at 6 to 12 hours after the event, reveals the true extent of the loss, and we have a reference there, fair enough. If your patient is ordered every 6-hour H&Hs or every 12-hour H&Hs, I would say that there would be something off there. So I would look for something more than just a normal acute blood loss anemia. I would look for something like maybe a liver laceration. You know, was that pediatric patient involved in a car accident or a rollover or a trauma? Did they fall and maybe injure their liver? So just always remember, when you see something odd, there has to be a reason behind it and probably a diagnosis to go along with it. The acute blood loss anemia can be defined as a drop of hemoglobin hematocrit significant enough to cause the physician to closely follow or treat, or maybe give iron transfusions of packed red blood cells, or maybe an iron supplement. There's not a specific percentage drop in hemoglobin that defines acute blood loss anemia, but after surgery or trauma, when the hemoglobin drops to the point that it causes clinical concern, coders and CVS may query for acute blood loss anemia. It's important for physicians to understand that often acute blood loss anemia is expected phenomenon, especially after major surgeries. And acute blood loss in situations like this is not necessarily a complication, but it's just a natural occurrence, and it needs to be documented. So that's why the physician would need to be queried. So to the next slide, some causes of acute blood loss anemia. We would have anemia due to acute GI bleed, acute blood loss after surgery, anemia of chronic GI bleeding over a long period of time, or blood loss from a trauma. Okay, on to our next slide, acute versus chronic blood loss anemia. So our hemoglobin hematocrit levels for acute blood loss during and immediately following hemorrhage decreases once the bleeding is controlled. The type would be normocytic, and the etiology massive and rapid hemorrhage. So there either would have to be a major surgery or a major injury. With chronic blood loss anemia, your H&H depends on the etiology, just maybe slowly, like a slow type leak. The type would be microcytic, but it again depends on the etiology, and the etiology is a chronic bleeding or iron deficiency anemia, one or the other. Your hematocrits here you can see on the screen, lower limit by age, so 0 to 28 days. Your hemoglobin is 10 to 23, your hematocrits 30 to 70, and at the higher end, your male and female 18 to 49, female 12 and 37, your male, your H&H would be 14 and 40. The next slide, neonatal anemia versus anemia of prematurity. So anemia is defined by the hemoglobin hematocrit value that is more than 2 standard deviations below the mean for the age. A lot of times physicians will document neonatal anemia, and we just sort of have to get them into the practice of saying anemia of prematurity. Again, anemia of prematurity is hyporegenerative, normocytic, and normochromic anemia. Pathophysiology of hemoglobin nadir, term versus preterm. So the hemoglobin is 11, and their nadir would hit about at age 12 weeks. Preterm is 7 to 8 of the hemoglobin, and their nadir would hit about 4 to 8 weeks. So yeah, and if you do see neonatal anemia, we could just query and have the neonatologist document for us anemia of prematurity. On the next slide, we have a post-op anemia case study. So here we have a 4-year-old that's admitted with cholecystitis, and they underwent a lap cholecystectomy. After surgery, the hemoglobin and hematocrit did drop. CBCs were monitored, and packed red blood cells were transfused. So if we move on to the next slide. Right now, we're grouped to APR-DRG 263 with an SOI of 1. So we are in the cholecystectomy, lap cholecystectomy DRG. And if we do query the physician for the cause of the drop of the H&H and the fact that packed red blood cells were transfused, and if the physician does rule in his documentation acute blood loss anemia, the severity of illness increases from 1 to 2. Again, your relative weight increases, as you can see. Reimbursement goes up. Your quality scores are much better, and it's a better outcome the whole way around to have acute blood loss anemia documented instead of just what the initial documentation had said. Okay. So we're going to go on to the next slide. Okay, so this would be talking a bit about respiratory distress syndrome. So in the first few days of life, neonates may develop respiratory distress syndrome. And this respiratory distress syndrome occurs in preterm neonates within about the first 6 hours of life. Signs and symptoms of it are cyanosis. The neonates treated with oxygen to maintain oxygen saturations. X-rays may show a reticulogranular pattern in mild cases. In severe cases, the chest X-ray may just be a total whiteout. So with these children, when they develop respiratory distress syndrome, that would be classified from day 0 to day 28. And so once they hit about the 28th day of life, they would fall into a category if they continued on with the respiratory distress syndrome, which many of them do. They now fall into a category called bronchopulmonary dysplasia. And when you would enter into the encoder the diagnosis of bronchopulmonary dysplasia, as a secondary diagnosis, you'll see that it will increase your severity of illness and risk of mortality because you're utilizing a lot of resources with these neonates. The bronchopulmonary dysplasia diagnosis would go from about day 29 up until age 3 to 5. There are different schools of thought on when the bronchopulmonary dysplasia diagnosis will come to an end. Some schools say at the age of 3, some schools say at the age of 5. So, okay. Next on to respiratory failure. In the pediatric population can be defined by the treatment the child receives. So children on any type of respiratory support, either non-invasive or mechanical ventilation, or greater than or equal to 4 liters of oxygen, can carry a diagnosis of acute respiratory failure. So you want to look for clinical indicators, including but not limited to. So look for your intercostal retractions. You want to look for nasal flaring. You want to look for any labored breathing, increased respiratory rate. So you want to go to your vital signs right away and look for your respiratory rate. You want to look for any cyanosis, any grunting, things of that nature. Chronic respiratory failure is usually recognized by a combination of chronic hypoxemia, hypercapnia, compensatory metabolic alkalosis. So you would see elevated bicarbonate levels. So that's another thing I look at a lot, look at your CO2 levels. Typically, patients with chronic respiratory failure require supplemental home oxygen therapy. So the diagnosis should be strongly considered for any patient with HOMO 2. Anytime you have a child or even an adult that crosses your emergency department door and they're coming in with any type of oxygen, always think of chronic respiratory failure and query for that, whether you're coding in the MSDRG world or the APR-DRG world. In the MSDRG world, you'll acquire a CC. In the APR-DRG world, it should increase your SOI and or ROM, depending on the principal diagnosis. So we're going to go down to our respiratory failure case study. And here we have a term baby boy admitted from the ED for acute respiratory distress evaluation and observation for neonatal sepsis. So they're thinking in the ED that the patient may have some sepsis. Diagnosis, term infant, acute respiratory distress. They've done some studies and found that the neonate has bilateral chlamydia pneumonia in the right lower lobe, the right upper lobe, and the left upper lobe. Stabs post wheezing and anemia. And in this first scenario here, the discharge summary states the infant was admitted with pneumonia that was positive for chlamydial pneumonia, received course of antibiotics, and is being sent home on azithromycin for continued treatment. So if we go down to the next slide, please. We would be grouped to APR-DRG 139, and we have some secondary diagnoses there of respiratory distress and anemia. And our severity level is at 1 right now, and it's minor. But what we want to do is I'm just going to have you go down to slide 32, please. So if, the next slide down. Great. So if we just read along here, the first paragraph states what I had just stated. The second paragraph, the record indicates the diagnosis of acute respiratory distress following the clinical findings and treatments were noted. Neonatal attending says seesaw breathing, subcostal and intercostal retractions, cyanotic and hyporeactive upon admission to the ED. First venous gas, 7.16, 87, 37, 31, and 2, which improved to 7.29, 63, 22, and 30 on 10 liters of high flow oxygen at 40%. The NICU progress note the next day states to CPAP of 7 for increased work of breathing, modeled and Dusky on admission. So you can see that he had this neonate needed 10 liters to recover, and then from the 10 liters had to be placed on CPAP. So the need for the oxygen was increasing. They described increased work of breathing, which is another clinical indicator, modeling, and duskiness. So in this case, what we would want to do is we would want to tee up a query for acute respiratory failure secondary to chlamydial pneumonia. And what that would do was, if you can just back up one slide to 31, sorry about that. Thank you. So now we would group to DRG, APR-DRG 139 with a severity illness of 3. So your severity went from a 1 to a 3, which is huge. Your relative weight increases, severity of illness increases, your reimbursement increases, your quality scores increase. You're telling a much better picture about this patient and a more complete picture of this patient. So, and I just had a few notes here. Sometimes in the APR world, the APR world is a little bit of a different animal than the MSDRG world. In the MSDRG world, we're pretty comfortable, and we know what a CC is or an MCC, and we know how to move our DRGs, upward or downward as we need to. In the APR world, I have found that sometimes the strangest diagnoses or the things that you would never think that would move your DRG actually do. So depending on what your principal diagnosis is, I've found that I really like to look at the electrolytes and like all of the electrolytes. So not only your hyper and hyponatremias, but look at your calcemias. Hypo and hypercalcemias will move SOIs and ROMs. Hyper and hypophosphatemias will move SOIs and ROMs. Hypo and hyperchloremias. Now, of course, when you query your physician, you want to make sure that there's clinical significance, that there's treatment and monitoring. And sometimes the physician will come back and say that, there really is no clinical significance to the hypo or hyperchloremia, for example. But sometimes they do rule that in, and that's just the thing you need to move that severity of illness from 1 to a 2 or a 2 to a 3, and sometimes even from a 3 to a 4. The other thing that I found that sort of shocked me was subluxations. And if you have a subluxation in one area of the body, maybe say you have like a fracture of a hip and you have a subluxation in your spinal area, as long as the subluxation isn't where the fracture site is, that will also increase your severity of illness and risk of mortality. And in some cases in the MSDRG world, it'll act as a CC for you. So these are just some things that I've learned along the way and that I did want to share with you. I do want to thank you very, very much for having me today. I truly appreciate it. And I would like to entertain any questions if you all have any questions today.
Yeah, Marianne, it does look like we do have one question, and it's as it relates to how long is the treatment needed to be considered respiratory distress or failure?
I would say as long as there would be an increased need of oxygen. So if the patient came in and they weren't on oxygen and then had to be placed on oxygen, also I have some policies and procedures that I've written for some children's hospitals, and I would be happy to share that with you if you would like me to. Would you like me to do that?
Yeah, I think we can.
Okay.
Absolutely. It seems like they've received some denials, from insurance as it relates to, treatment of O2 or BiPAP was not higher long enough. It seems to be, the impact of denials as it relates to around that question.
Okay. And I'll tell you what, with denials, I think every day it gets harder and harder, and I think the insurance companies are, placing more and more restrictions. So if you give me some time, I can send the policy over to Chris, and also I can try to look into that a bit for you. If you can give me a little bit more information on your end, I'd be glad to help as best I can.
Okay, fantastic. And it also looks like there's another question. I think that this is, one that's been common for us as it relates to, conversations from, Medevent Solutions side, just, entertaining expansion into programs is, the overall kind of ROI, particularly, revolving around, the NICU aspect to pediatrics. Anything that kind of comes to mind as it relates to, major areas of focus, not just revolved around that ROI aspect, but also around the quality that would kind of, at least give some folks, something tangible to walk back with as it relates to, a potential, need within that NICU environment.
Yes. I've worked with some neonatologists, and we discussed many times malnutrition, for example, and I've never met a neonatologist that would readily document malnutrition. So I think that the infant needed to be in the NICU for quite some time. I'm saying maybe 2 to 3 weeks or greater, and they weren't gaining that weight. And it was pretty much only after that period of time, weeks, that they would even entertain documenting malnutrition. So I know that's a very difficult diagnosis for them, but if we can maybe educate our neonatologists about that, if the neonate isn't gaining weight and still has the signs and symptoms of the malnutrition, et cetera, that would be one diagnosis. Sometimes you'll see on your neonatal charts things like the physician will document both acute respiratory distress and they'll document acute respiratory failure or acute respiratory distress syndrome, excuse me. And basically what's going to happen there is the acute respiratory distress syndrome is going to trump the failure. The failure is going to roll up into the distress syndrome, and the distress syndrome will be coded, not the failure. So they just need a little bit of education on, one versus the other. That would be something else that I would tell you to do. Any other types of failures, if they have a congestive heart failure. I know some even larger general type hospitals that have NICUs, for example, will have cardiologists on call or have a cardiologist come in a few days a week. So sometimes you could query for those types of things, congestive heart failure. Those would be just a few things for ROI. If I can come across any others, I'll be glad to email them over to Chris, and then he can disperse those. Is that helpful, Chris?
Absolutely. You know what? We have another one as it relates to, NICU providers that use, Vermont Oxford Network criteria, or BPD. Often, it looks like their pets are not real to support, over 28 days, but not using O2. I'm not sure if you have any, kind of thoughts on that aspect.
Okay. Could you just repeat that? I'm sorry.
Yeah, sure. No worries. It looks like it's in relation to the Oxford Network criteria for BPD, aiming as far as, being able to support the over 28 days, but not using O2.
I'll tell you what, I will get back to you on that one. What I was always taught and what I learned was that 0 to 28 days would be the acute respiratory distress syndrome. And then right at that 29th day to H3, they did term that as bronchopulmonary dysplasia. But I will look into that and get back to you on that for sure.
Okay, cool. We definitely have some questions coming in. So this is great from an interactive perspective. It says on RDS, is it necessary for them to document type 1 or type 2? Seems like that may be, an audit risk.
Yeah, probably better to document the type 1 and type 2. I believe there are two different codes, and I think that the more specificity you have, the better off you'd be. So I totally agree with you on the audit risk, and I would try to get the type if you can.